Is saturated fat the prime culprit in cardiovascular disease? In today's podcast, Dr. Chris Knobbe, a physician and ophthalmologist turned ancestral nutrition researcher, renowned speaker, and public health advocate, and myself will be answering this exact question. In this episode, we will not only show you the statistics, but we will also dive into the direct mechanisms of cardiovascular disease. Now, before we jump in, if you would like to take your understanding of some of the most important culprits of chronic diseases like cardiovascular disease to the next level, I'd highly recommend checking out Dr. Chris Knobbe's book, The Ancestral Diet Revolution. In this book, Chris has taken Dr. Weston A. Price's work to the next level, detailing the relationships and mechanisms of processed foods in driving chronic diseases like cardiovascular disease, diabetes, and obesity, while also simultaneously comparing the ills of modernized diets to the wisdom of ancestral diets. Now, to preface this conversation, there's something important that I want to lay out first, and then we'll jump right in. Cardiovascular disease is a multifactorial process that is typically a culmination of a variety of pathologies converging together. So there's a lot of different pieces that are moving and can be directly involved in driving this process. This podcast is not meant to disregard these other pieces or to downplay their importance. More so, what we want to talk about here is the highlights of some of the pieces that we believe to be some of the most significant contributing factors. So with that said, welcome back for the third time here, Chris. As always, I'm honored to have you here with me. In our last podcast, we discussed seed oils as prime culprits in chronic diseases like diabetes and obesity. But today, the question is, what about diseases like cardiovascular disease? So with that said, can you start us off with the history of cardiovascular disease and then show us the relationship between cardiovascular disease and saturated fatty acids? And I guess from there, we'll get into seed oils.
Sure. Well, first, thanks for having me on again, Mike. It's really an honor and a pleasure to be on your show. I appreciate it immensely. Think we're going to have a lot of good things to cover today. So let's start here with coronary heart disease. So many people really don't realize that coronary heart disease was extraordinarily rare in the 19th century. And as far as we know, for all of history before that, you can see here that there was one documented coronary heart disease death in the United States in 1912, and we're going to get into some of this detail later. And it actually, coronary heart disease then just exploded up until 1972, and we'll get into the numbers shortly, but then began to decline. But even by 2012, so a century later, we still had 371 some thousand deaths. Now, if we just look at these two numbers, one in 1912 that we know of and 371 some thousand, this is more than a 37 million% increase. Now, it may be smaller, but we'll get into that. Now, so I'm going to take us back here to 1859 in Sweden when this physician, J.P. Malmsten, attended to a patient that presented with the most unusual syndrome. And this syndrome was primarily based on his symptom of what we would now call substernal chest pain. And despite Dr. Malmsten's best efforts after this patient presented, 6 days later, he died. And this case was so unusual to Dr. Malmsten and to the attending pathologist that they decided to present it at the Swedish Medical Society that year. So the attending physicians were, again, J.P. Malmsten, MD, and professor and pathologist von Deuben. And so that people know, both of these physicians, Malmsten and von Deuben, were of the Karolinska Institute. They were considered highly prominent, esteemed physicians of their day. So they presented in September of 1859 at the Swedish Medical Society, and you won't be able to see the images here based on the way that our PowerPoint's set up here, but it's a small venue and maybe less than 100 people, but they're all physicians of Sweden. This is what Malmsten and von Deuben said about this patient. They said he was a 66-year-old male. He presented on Wednesday with cramp-like pains under the sternum. On the Friday, a quarter grain of morphine was given, again by Malmsten. And then the following Tuesday, Malmsten reported, quote, 1 hour after I had left his bedside, the patient was attacked by severe choking. His chest labored severely. His face became blue. And after a quarter of an hour of agony, he died. Now, Malmsten then told the Swedish Medical Society, all the members, he said, quote, the diagnosis was obscure. The next day, the Professor von Deuben completed the autopsy. And now, more than 100 years later, in 1980, Swedish physicians then, after reviewing the literature, determined that this case in 1859 was the first known or documented clinical pathological description of heart attack, myocardial infarction, the first case. And then in this century, in 2012, I believe it was, a researcher, physician in the UK, David S. Grimes, wrote this paper entitled An Epidemic of Coronary Heart Disease. And he referred to this first case of heart attack and the paper in the 1970s by the Swedish physicians. And this is what he wrote about it. The quote, the earliest clinical pathological report of coronary heart disease was in 1859, an anecdotal case report of myocardial infarction presented to the Swedish Medical Society. The report was not known outside Sweden, and at the time, it did not appear to be important. It's very true. It wasn't important in 1859. He said, quote, or wrote, the fact that this was a single case report was emphasized by, and he named the Swedish physicians that wrote the previous paper that I referred to. He said they drew attention to the 1859 report, contrasting it with 770 new cases of MI, that's heart attack, occurring in Malmö, Sweden in 1978 alone. Now, I just want to mention here that the population of Malmö, Sweden in 1978 was 237,000 people. And of those, 770 had heart attacks that year. Yet in the entire world, as far as we know, there was one heart attack in 1859. So let's go back here. So in 1859, the physician J.P. Malmsten, by the way, was 47 years old. He'd been in practice for 20 years. He was highly regarded. He was a member of the Karolinska Institute. My question is with this presentation, substernal chest pain, and this patient laboring severely and dying, how could it be, if we think in today's terms, how could it be that these physicians don't know what this is? And the obvious answer is this was the first ever heart attack, right? This case was, to them, absolutely incredibly bizarre. Right? Okay, right. That's 1859. So about 30 years later, Mike, this physician enters the picture, Sir William Osler, MD. So for those who don't know him, Sir William Osler is the most famous, highly regarded, esteemed physician of the last several centuries, unquestionably. Osler is known primarily because of his textbooks, The Principles and Practice of Medicine, that he first published. This is the picture of his first textbook in 1892. And this is my copy, Mike. This is what it looks like. You can see this is an old textbook. Now, much has been written about this textbook, but I'm going to mention regarding coronary heart disease. So in 1960, Harold File wrote this about the textbook. He said, coronary heart disease with heart attack was, quote, not a subject of review because, quote, myocardial infarction had not yet been diagnosed clinically. That's true. In 1892, it had not been diagnosed clinically. But I will mention, because I have read this Osler's Principles and Practice of Medicine, I've read a lot of it, and he was aware of rare cases of angina. He mentioned, quote, fatal cases of angina, but which is angina is the chest pain that the precedes sort of crushing substernal chest pain that we typically think of with heart attack. I'm sorry, what'd you say, Mike?
I said the chest pain that typically precedes heart attacks, or at least you get angina and then over time it develops into full-blown heart attack. I guess my question here, so basically just to lay out what you discussed so far, Chris, is that it's not you're saying that people didn't have heart attacks maybe even before the 1859 time. It was just that it was such a rare occurrence that we had only had gotten one documented case of a heart attack in 1859 by this point by a Swedish physician who had already had 20 years of practice. So basically the point is that the heart attacks and even cases of angina where you have that substernal chest pain, the crushing pressure with activity, that was actually like extremely rare. And then you're saying even Sir William Osler is saying that there's not really that many cases of people seeing this up to this point. And these are some of the most prominent physicians and I guess medical researchers of this time frame.
That's exactly right, Mike. And I'll give some further detail on this. But yes, I'm sure there were some rare heart attacks in the world, but they were exceedingly rare, as you're going to see next. So this is again, the previous textbook published in 1892. Now, a few years later, 1897. William Osler wrote these words in a paper. He wrote this, quote, "Angina pectoris is a rare affection in hospital practice. During the 10 years in which I lived in Montreal, Canada, I did not see a case of the disease either in private practice or at the Montreal General Hospital." He continued, "At Blockley, which is Blockley Almhouse, later known as Philadelphia General Hospital, Two, he said, it was an exceedingly rare affection. I do not remember to have had a case under my personal care." He continued, "During the 7 years in which the Johns Hopkins Hospital has been opened, there have been only 4 instances of angina pectoris." So let me review this quickly, Mike. So he said, from what he reviewed, during a 21-year period of both his hospital and private practice experience between 1876 and 1897, Osler recounted only about 6 cases of angina. Perhaps not a single one of those was led to a coronary heart disease death. And this is a picture of Johns Hopkins Hospital. It was opened in 1890. And again, in that period, that 7-year period between 1890 and 1897, Osler recounted 4 cases of angina pectoris, perhaps none of which were fatal. And this hospital was the 3rd largest hospital in the United States at that time. So, and people who think that physicians weren't intelligent, boy, I tell you, back in those days, they were smart as whips. Their clinical skill was so beyond ours because they didn't have MRIs and EKGs and all these, they couldn't draw cardiac enzymes and all these things. They had to rely on their clinical skills, and they were fantastic. All right, so that was 1897. So 13 years later, in 1910, Osler goes to London, England, and he presents here at the Royal College of Physicians. And at this conference, where it's all physicians, he said he tells the audience that between 1897 and 1910, he sees an additional 208 cases of angina. And this is what he says to the audience, Mike. He says, quote, "Has angina pectoris increased in the community? Has the high pressure life of modern days made the disease more common? There is an impression among consultants in the United States that there has been an increase during the late years." All right, so that's 1910, right? Now, back in the United States, 2 years later, this physician, James B. Herrick, documents the first heart attack, first myocardial infarction in the United States. And that same year, he publishes this paper on it called the title is "Clinical Features of Sudden Obstruction of the Coronary Arteries." You can see it came out December 7th of 1912. And he elected to present the case here, so he submitted this ahead of time. And in 1912, that same year, he presented his paper here for those who could see this at the Association of American Physicians. This is a big conference. And this is what he said about his presentation. I think this was 6 years later, if I remember right, Mike. This is what he said. "In 1912, when I arose to read my paper at the association," that's the Association of American Physicians, "I was elated, for I knew I had a substantial contribution to present. I read it, and it fell flat as a pancake. No one discussed it except Emanuel Liebman, who's the moderator. And he discussed every paper read there that day. I was sunk in disappointment and despair. No one cared." Now, we're going to jump ahead to 1941. And this is what he says later when he's an older, he's an older man. And he says, quote, when it was presented, his presentation, he said it was discussed by only one person. There was no repercussion for 6 years. It had fallen like a dud. Now, I just want to mention, no one took coronary heart disease at this time seriously. This single case report, that to them, it was like seeing a case of malaria in Denver, Colorado. They're just going to think they're never going to see this again. What's the big deal? Why do we need to have any interest in this? So that was how physicians and people reacted pretty much there and probably around the world.
Just a quick recap here. So basically, in the early 1900s, at least, and then I guess in the latter, with Sir William Osler, he was seeing an uptick in the angina cases that, in his practice, from the end of the 1800s to the early 1900s. But even in the U.S. by that point in time, you have a physician, Dr. James Herrick, who's talking about the first case reported heart attack in the U.S., and he's presenting it at a huge conference, like one of the biggest conferences for other physicians, and nobody really cares about heart disease. So basically, the overarching picture here is that there wasn't really that many documented cases of heart disease or even angina at this point. It wasn't even heart attacks. It was just having chest pain on exertion, or maybe having chest pain without exertion. But we're not really seeing this within the population. We're looking at some of the most prominent physicians working in some of the biggest hospitals. So it's a way to basically show, like, we're not really seeing much heart attacks, right? Maybe people have some plaque development. Maybe they have some of this other stuff going on, but it's not manifesting in full-blown cardiovascular disease deaths. And it's not manifesting to the point that physicians actually even care, because they're having a paper presented on this. And for 6 years, there's no statement on this. And again, this is like in the early 1900s, we're seeing this, just about 100 years ago. We're basically seeing like very minimal heart disease at this point. Like, this is the overarching encapsulation of what we're seeing, correct?
Right. Yeah. So people died of quote heart disease. Today, when people mention the term heart disease, everybody thinks of coronary heart disease, but the cardiologist will laugh at you if you just say heart disease and you don't, you automatically think it's coronary, because that's what we tend to think of. But in 1900, people did die of quote heart disease, but almost all of it was cardiac valvular disease, which is induced by infections. And so this was primarily syphilis, endocarditis, and rheumatic fever. That's what people were dying of. They weren't dying of, this is what I'm saying, they didn't see coronary heart disease. It was a rare thing. So if we jump ahead now, Mike, up to, this is a paper that was published in Scientific American in 1980. And the title of it is The Rise and Fall of Ischemic Heart Disease. And we're going to see that there was this gigantic increase in coronary heart disease deaths in the U.S., and then it already by the 1970s had begun to fall. So this is a graph that was published in the journal Circulation in 2010, and you can find numerous graphs like this. We're going to show a couple more later on, but as you can see, cardiovascular disease deaths were very, very low in 1900, and then peaked around 1970-ish, and then began to drop off. And so what we did was, we actually tried to estimate all the coronary heart disease deaths in the U.S., because that's hard to do. It's hard to separate those. I'll go through some of these numbers. In 1912, it said there was one coronary heart disease death in the U.S. That's one James Herrick's case, right? But I changed that to, we did from about 1 to 100. And again, these are estimates. By 1922, it's estimated that 100 to 500 CHD deaths in the U.S. 1932, 7,000 to 15,000. 1942, these numbers start getting really pretty accurate. 1942, 40 to 60,000. You can see that doubles again are more than doubles by 1952. That doubles again or triples by 1962. 1972, we peak at 684,000 deaths from coronary heart disease, and then it begins to decline. And by 2012, we're at 371 some thousand, and it's exactly the same in 2022. It's 371 some thousand. So if we go back to this graph and we see that, again, that there was one documented coronary heart disease death in 1912 and 371 some thousand in 2012, a century later, this would be a more than 37 million% increase. But even if we assume there was 1,000 coronary heart disease deaths in 1912 and there's 371 some thousand in 2012, that's still greater than 37,000% increase. And I point this out, Mike, because we have all of these papers, scads of them, that are looking at all Americans together and trying to split hairs between their PUFA consumption, their saturated fat consumption, sugar, all these things, draw quintiles, and then determine that those who consume a little more PUFA, for example, have a 15% lower cardiovascular death risk or something like this. I'm not giving any exact numbers here or any specific paper. I'm just saying that the numbers are absolutely trivial compared to if you look at the big picture and what's happened with heart disease in relation to vegetable oil, for example.
And just before you go on, Chris, just one thing. On the last graph that you had us on, you're basically what you're saying is that even if you estimate for like 1,000 times difference, like you give a buffer of 1,000 times for the number of coronary heart disease deaths in 1912, you would still see a 37,000% increase in cardiovascular disease from 1912 to 2012. So in a 100-year time frame. And this is specifically deaths. So it's not just people, oh, my chest kind of hurts after I walk a bit, or my blood pressure is a little high. It's people specifically dying from cardiovascular disease.
Specifically dying of, this is coronary heart disease, specifically.
Coronary heart disease deaths, yes.
Yeah. So it's an extraordinary number. And you can say that this is correlated to, and you're going to see, to vegetable oils. Now, these are the references for all of that. But if we move over to the United Kingdom and we look there, you can see it's almost the exact same thing. You can see that, and these are all published graphs. You can see, and these are CHD, coronary heart disease deaths. You can see in 1931, the numbers were really small. They don't have anything before 1931. But you can see that it peaks around 1980-ish, and then it's coming down. And that's for men, and here's for women. There's on this one seems to peak, on the crude number seems to peak quite a bit later, like in the 1990s. And if we go back, and people will say, but the population's increasing a lot, right? Well, yep. So this accounts for that. So this is CHD deaths per 100,000 population. You can see it's the exact same thing, that the CHD deaths peak enormously in the late 60s, in the case of the UK, and then it's coming down. And this is for women, same situation. And again, they peak around 1960s or 70-ish, and then it's coming down. So in the United Kingdom, 170,000 people died of cardiovascular disease and 66,000 of coronary heart disease in 2022. So their numbers parallel ours very well. If we go to the world, Mike, if we look at the whole world, here, this is a paper from the World, or not a paper, this is a article from the World Heart Federation. And the title is Deaths from Cardiovascular Disease Surged 60% Globally Over the Last 30 Years. And this is their graph that you can see that there was 12.1 million cardiovascular disease deaths in 1990. And that increased 60%, as they said, to 18.6 million by 2019. So if we just review this briefly. So again, on a global scale, there's one cardiovascular disease death in 1859. Maybe there's dozens, maybe hundreds, but the numbers were awfully small in the 19th century, right? By 2019, 9.1 million coronary heart disease deaths and 20.5 million cardiovascular disease deaths. Well, what is this tied to? Again, as I already alluded to, look at the parallel here we see with the increasing vegetable oil consumption. You can see that back in 1865, we had no seed oil consumption at all. There wasn't soybean, corn, canola, cottonseed, grapeseed, sunflower, safflower, rice bran, peanut, or sesame oils. None of those. They had a trivial amount of olive oil, and that was it. And almost nobody could get it, right? So, but the seed oil consumption and the approximate vegetable oil consumption for the United States was 0 grams per day in 1865. And this is our published graph. And you can see that by 2010, we're at 80 grams per person per day. That's 720 calories worth of seed oil consumption. Now, there is some plate losses here because this is FAO data, and this is the amount of vegetable oil that would reach the consumer. And by the way, this is total vegetable oil. And people will say, well, what part of this is industrial seed oils? And the answer is in 2010, 89%. 89% of this is what the oils I just mentioned, soybean, corn, canola, cottonseed, all those. That the other 11% is made up of a tiny amount, about 2.7% of olive oil, and then coconut oil, palm kernel oil, and a few others make up that other 11%. So people love to talk about olive oil, but almost nobody's eating it in significant amounts. I mean, broadly speaking, in 2010, I think it was 2.7% of the U.S. consumption, and it's around 1% globally, I think, if I remember the number right, but it's something like that.
And just something to when you're talking about before the FAO data, what you're showing is the availability of these things, because you're looking at basically economic charts so there may be, when you're saying there's some losses, there's probably some losses in actual consumption because there's a gap between the food availability and food consumption. But even with that, there's still a massive increase in the vegetable oil consumption from the 1860s all the way up into 2020. The only thing, I guess, going with this is we do see a drop off in cardiovascular disease deaths, though, even though we see a continual increase in the vegetable oil consumption. So I guess the question is, like when we saw with sugar, vegetable oil with diabetes and obesity, we saw that there was divergence in the graphs between sugar and obesity and diabetes, right? You parsed that out in the previous presentation. But here we're seeing what seems to be a divergence between the vegetable oil consumption and the rates of cardiovascular disease. So what do you think explains some of this?
Yeah, so if there's certainly other drivers here. We're going to get into some detail, but so here is that graph again. One documented coronary heart disease death to. Go ahead, Mike.
Yeah, so there's the drop off, right? So we see the peak in 1970s.
Yeah.
And then we see our drop off. But like what are the other factors that we saw what are the other factors that would have contributed, at least from your model, that helps to explain why cardiovascular disease deaths have dropped off even though seed oil consumption has continued?
Yeah, so the main one is smoking. And we know that from the CDC that smoking increases coronary heart disease and stroke 2 to 4-fold. And if you look at it here, this is the smoking prevalence in the United States versus the CHD deaths. And you can see that smoking in the United States peaked, I think, in 1948 or 1950. It's right here. And then it began to come down. And the coronary heart disease deaths peaked at 1972, so almost precise, right around 20 years later, and then the CHD deaths are coming down. right? So this makes sense that, because smoking is going to have a very long lasting effect. So it's going to take a long time for the drop off is actually pretty slow in smoking prevalence, but you can see that they do follow one another about 20 years apart. Um, and and this is a paper that addresses this issue, Mike: decline in cardiovascular mortality, possible causes and implications. And here's what they state: models have shown that this remarkable decline in CHD deaths has been fueled by rapid progress in both prevention and treatment, including precipitous declines in cigarette smoking, improvements in hypertension treatment, and control widespread use of statins to lower circulating cholesterol levels, and the development and timely use of thrombolysis and stents in acute coronary syndrome to limit or prevent infarction. And this is another paper that came out recently in the New England Journal of Medicine, called A Tale of Coronary Artery Disease and Myocardial Infarction. And in this paper, they review all of the factors, the treatments that cardiology, primarily our physicians, have provided to patients over the years. And you can see here, I just highlighted some of them, that the first open heart procedure was in 1954, 1969, the first coronary artery bypass graft, which, by the way, the bypass grafts have not been shown to extend lives. But they have helped, with patients to have better lives. They have less symptoms. 1977, you can see coronary angioplasty was developed. 1980, first implantable cardiac defibrillator. Around 1983, coronary surgery. 1985, thrombolytic therapy introduced. Stenting by 1993 shown to be valuable. And then in the 2000s, you can see antihypertensives and lipid lowering agents all play a role in decreasing these cardiac deaths.
So basically, the drop off in smoking and improvements in treatments of cardiovascular disease are some of the major components that have actually decreased cardiovascular disease deaths, even though seed oil or vegetable oil consumption has continued to trend up. And on top of that, diabetes and obesity have trended up. So we basically got better at treating it, and people are smoking less because of some of the public health things that went out about stopping smoking. But I guess the other thing as well is that cardiovascular disease still is the leading cause of death. Yes?
It absolutely is. Yes. Yeah. So as this paper shows, heart disease remains and this was published this year, January of this year, 2025. Heart disease remains the leading cause of death as key health risk factors continue to rise. And this is for the United States. And you can see here, look at this is total heart disease, of course. That's not just coronary heart disease, but 681,000, and stroke about 163,000. So yes, we have huge numbers of people dying every year. Again, this is the leading cause of death, cardiovascular disease in the United States.
And I guess just to contrast this again, if we go back to the graph that you had, in the early 1900s, that we weren't really seeing this amount of total cardiovascular disease, but also coronary heart disease, strokes, and stuff like this. This is a phenomenon that's specific to this time frame, and that's despite it's still very high, despite us treating it and people being better at treating it, right? With medications, antihypertensive, lipid lowering agents, surgical procedures, stenting, coronary artery bypass, etc. It's still it's still the leading cause of death in the United States at this point. And I would probably venture to guess that the rheumatic heart disease and then valvular issues have probably decreased significantly since the advent of antibiotics, and that most of the cardiovascular disease at this point is probably more related to heart attacks, heart failure, and disease processes like this than it is related to some of the older things that we would have seen with rheumatic heart disease and valvulopathy.
Right. So if you were to go back to 1900, people dying of a cardiac valvular disease, like rheumatic fever, that would have been much more common. We don't, because of antibiotics, primarily, we don't see these conditions very often anymore, at least not to the degree that they're causing death. And they're also treatable surgically. So we've had a complete shift. Back, like I said, people did die of cardiac diseases, but they were mostly valvular at 1900. And today they're almost all coronary artery disease related.
All right. So I guess at this point, what I want to do to add to the statistical analysis that you've put together for us, Chris, with the vegetable oil consumption and cardiovascular disease, and also showing us why things have dropped off, is that I think that the mechanistic component is really important with the overarching picture, so that we see not only the relationships and the statistics, but also what's going on with the process. So I think in order to actually understand where vegetable oils come into this picture, we need to first get an overview of heart disease and how it develops. And then from there, we'll talk about where the vegetable oils play a role, because I think there's a lot of confusion in there. And it's going to take us down an interesting road. So the first piece here, and this is just an overview. I have more in-depth presentations that you can check out on the Mike Fave Science YouTube channel, where I walk through the progression of cardiovascular disease. But this is going to give us a quick overview so that I can set the stage for us to talk about where vegetable oils play in here. And essentially, when we look at cardiovascular disease, or specifically coronary heart disease, what you start to see is a progressive increase of lipid deposition into the intimal layer of the artery. So it's this middle layer here that we see in the artery. And this usually starts off with an inflammatory event or some type of oxidative stress event or damage to the artery. And then you start to see what's called neo-intimal thickening. So you see this middle layer of the artery starts to thicken a little bit. Now, this can stay like this or it can regress over time. But as the intimal layer starts to thicken, you can also start to get deposition of lipids into this layer. And a lot of times the lipids, and you can see this here based on the LDL, oxidized LDL, and this is going to be really important when we get down into the mechanistic piece, is that the lipids, the LDL particle in the bloods, tend to have to be oxidized to really get this thick plaque formation, this fatty formation inside the blood vessels, with the subsequent immune cells coming in, the macrophages, that will then eat, essentially, kind of like in a Pac-Man fashion, the oxidized lipid particles and continue to build up this plaque layer. So as this progresses, you can start to get increased inflammatory signaling, increased immune activation, and the plaque starts to build and build and build. Over time, it'll decrease the lumen of the artery. You can start to get deposition in the plaque. This is where we see the coronary artery calcium scans. As the plaque increases, the inflammatory signaling increases. And then eventually, at a certain point, you have the capsule layer of the plaque. It's a connective tissue layer. This ruptures, and then eventually you get a clotting cascade on the rupture, where you get this blocking off of ultimately of the artery, and then you have a lack of flow. And this is what causes that heart attack. The occlusion of the vessel is through either the embolic event or the inflammatory signaling in here with the clotting that blocks off the artery. And then the doctor will come in, he'll put a stent, and he'll move this stuff aside, and basically you get flow back into the artery. But the big piece here where I think that we want to focus is with the oxidized lipids, right? Because you have these initial components, and they also talk here about F2 isoprostanes, which are markers of oxidative stress. Both these elements are going to become really important when we start to talk about cardiovascular disease, especially in these early initiating stages. So there's a hypothesis that we talk about with cardiovascular disease, and this gained traction in the 1980s. It was called the oxidized LDL hypothesis, or oxidized lipoprotein hypothesis. And basically, we have a quote here. And basically what the authors say here, they say the low density lipoprotein oxidation hypothesis gained traction during the 1980s because it's noted that in general, native unoxidized LDL, so your normal LDL that floats around, does not cause foam cell formation. So foam cells are those immune cells that come in and eat up the LDL particles. So in other words, LDL had to become oxidized first in order for atherosclerosis to develop. Indeed, it was later discovered that oxidized LDL caused direct toxic effects to the cell. Recruitment and entry of the monocytes, which are the immune cells, become macrophages, into the subendothelial layer and increase foam cell formation, leading to increased atherosclerosis and inflammation altogether. Now, this is actually from a paper from Dr. James D. Nicolantonio and James O'Keefe, titled Omega-6 Vegetable Oils as a Driver of Coronary Heart Disease, the Oxidized Linoleic Hypothesis. It's a great paper that I recommend people take a look at. But essentially what we can see here with the graphic is you have normal LDL, which is basically just a protein that has a bunch of lipids in it, because the lipids won't mix in water, right? Water and fats don't mix. And then essentially the lipids in here can become oxidized. And when they become oxidized, it damages the protein on here, the ApoB, which we can see the blue squiggly line here. And then the ApoB is not recognized by the LDL receptors anymore, so the cells can't take it up. The lipids continue to become oxidized, and eventually you get oxidized LDL. And this oxidized LDL is now recognized by immune receptors or inflammatory receptors called scavenger receptors, which you typically see on the macrophages that enter into the artery wall. So basically, the big takeaway here, all the crazy mechanisms aside, is that normal LDL, pretty benign for the most part. When you start to get LDL particles that are oxidized, damaged, or the ApoB proteins are modified, they basically are sending a message to the body, hey, we have a problem here, which activates the immune system. Also, we'll see in a second, damages the vascular layer. And then this is where you start to see some of the formation of cardiovascular disease. So what we can see here, this is just to show some of the effects of oxidized LDL on the vasculature. The authors from this paper, the paper titled OxLDL induces endothelial dysfunction and death via TRA-F3IP2 inhibition. Basically what they say is increased local and systemic levels of oxidized low-density lipoproteins, so oxidized LDL, induce endothelial cell activation, dysfunction, death, and impaired vasal relaxation. So the arteries aren't able to dilate, and they contribute causally to atherosclerosis development and progression. So oxidized LDL directly contributes to atherosclerosis and progression, development and progression, because it directly damages the endothelial cells. So the endothelial cells, we come back here, is this nice little layer that sits on the inside of the artery and controls the relaxation and dilation of the artery and a variety of different processes, some of the clotting cascade and things like this. So ox-LDL directly damages it. They say here in endothelial cells, ox-LDL signals mainly via the lectin-like oxidized low-density lipoprotein receptor, so LOX1, and activates diverse cellular secondary messengers, including nuclear factor kappa beta and AP1, two oxidative stress response to transcription factors important in regulation of cytokines, chemokines, and adhesion molecules. And they say some of the induced cytokines also activate the nuclear factor kappa beta and AP1 and can reinforce the inflammatory cascade. So basically, what happens is the ox-LDL interacts with this LOX1 receptor on the endothelial cell, and what winds up happening is it causes death to the endothelial cell. It activates the macrophages in the immune system so that they form foam cells, and then you have basically the vascular smooth muscle cells, which you find towards the intimal layer, that middle layer of the artery. Those start to get damaged. They undergo apoptosis. You can get an increased production of fibrosis or cells inducing like a scarring inside the artery, and then you get the macrophages get foam cell formation. So that's where we start to see this type of stuff happen with the oxidized LDL. So we see oxidized LDL is an extremely important driver of damage to the vasculature and also activation of the immune cells. So we can see the same thing here. This is another paper, oxidized low-density lipoprotein contributes to atherogenesis via co-activation of macrophages and mast cells. And they say here the other important result of our work is that ox-LDL can co-activate at least two types of tissue-resident cells, macrophages and mast cells. These are both immune cells. This co-activation induces macrophages and mast cells to release two powerful pro-inflammatory mediators. So basically, they signal inflammation, tumor necrosis factor alpha, and histamine. And so we can see that here in this image. Essentially, what happens is you have normal LDL here. It's fine. But when the ox-LDL interacts with the endothelial cells and induces endothelial dysfunction, they also signal the LOX1 receptor, and you get the monocytes come in, and they start to eat up the oxidized LDL, and you get foam cell formation, and this is inside the artery. So basically, when we look at this as a recap, normal LDL just takes the fats from your liver and brings them to your tissues. Shouldn't really damage your vasculature. It's just a transport process. It's basically the Amazon truck taking the package to the tissues. Oxidized LDL, that's where we see vascular damage and immune activation, which is directly involved in the atherosclerotic process. And then we can also see this here in humans. Basically, in people who have heart disease, ox LDL is higher. So this is from Dr. James D. Nicolantonio's paper. They say ox LDL was found to be higher in patients with coronary artery disease compared with normal patients, and ox LDL was able to better identify patients at an elevated risk of heart disease. Moreover, oxidized LDL and autoantibodies to ox LDL are found in atherosclerotic lesions. Furthermore, patients with progressive carotid atherosclerosis have more antibodies to ox LDL versus those without progression. So basically, the more atherosclerosis you see somebody have, or both relationships, you basically see more oxidized LDL, and the more oxidized LDL a person has, and also antibodies to the ox LDL, you tend to see increased atherosclerosis. So you're seeing this relationship between oxidized LDL particles and an atherosclerotic lesions in people's arteries.
Yeah, that's brilliant, Mike. I just want to ask next then, so if it's oxidized LDL that's driving atherosclerosis, driving coronary heart disease, coronary artery disease, cardiovascular disease, all of those, what is it that's the primary driver or drivers of oxidation of LDL?
So I guess when we talk about this, you know this as well as I do, but essentially you have some component that allows LDL to be oxidized, and then you have components that are inducing that oxidation process, right? So you can have inflammatory responses, metabolic dysfunction, exposure to chemical agents and stuff like this. They induce oxidative stress. But the question is how susceptible is that LDL particle to that oxidative stress? And one of the big components that determines susceptibility is going to be the types of fats present inside the LDL particle. And in this case, which goes directly with your hypothesis and why we're talking about this, is the linoleic acid specifically, and polyunsaturated fatty acids in general, but linoleic acid, particularly high omega-6 linoleic acid from seed oils, can increase the susceptibility of the LDL particles to oxidation, to being oxidized. So the one caveat and like nuance that I want to present with this is that it's kind of a dance. It's a tango, right? So you have this lipoprotein or this LDL particle that is loaded with polyunsaturated fats, particularly omega-6 linoleic acid, and it's highly susceptible to oxidative damage. And then on the opposite side, you can have a variety of processes that can create oxidative stress and then basically oxidize that linoleic acid. So the more linoleic acid you have within these lipoproteins, and then the higher oxidative burden you get this dynamic duo that comes together, and you basically start to, I think, drive this atherosclerotic process. So it's not just this by itself, I would say, or it can be, because the other thing is linoleic acid can oxidize even like just randomly. Like there's even a paper we'll talk about here, which is more linoleic acid in a diet, more oxidation products you see typically in people's tissues. So you have this, but I think that in conjunction with, say, micronutrient deficiencies that you would create on a modern diet versus an ancestral diet, or some of the exposure to some of the chemicals, different compounds, all of these elements will induce that oxidative stress on top of the metabolic dysfunction, which we talked about can be diabetes, obesity can be driven by the vegetable oil consumption, high linoleic acid content, by shifting what's going on inside the mitochondrial metabolism. Those can kind of combine together and drive this increased oxidized lipoprotein, because you have this increased oxidative stress on top of this increased susceptibility to oxidative damage from these fats. So I think it's this interplay, and we'll see this here, which basically goes with the linoleic acid or oxidized linoleic acid hypothesis of cardiovascular disease, which is something that was propositioned in the research by Dr. James D. Nicolantonio. And it directly ties in with your work, Chris. That's, I think, why it's so interesting, because you're showing these relationships with the vegetable oil consumption, these disease processes, and people will say, oh, well, that's just statistics. There could be so many other factors. And it's like, well, we also have mechanisms that play in with it. So we're not saying to just rely on statistical modeling. We're saying like, hey, here's like multiple lines of evidence that are showing part of this picture, and we have a lot of ways that this can make sense. And so basically trying to parse it out. So does that answer your question, Chris?
Yeah, I think that's brilliant, Mike. And I just want to mention that DeNicola Antonio and his co-author, I don't remember his name, but
Dr. James, I think it's James O'Keefe.
Yeah, James O'Keefe. They reviewed 66 papers that were in support of this linoleic acid, oxidized linoleic acid hypothesis of coronary heart disease. And so there's an extraordinary amount of support for this hypothesis.
Yeah, and this is like this. Basically, I walk through some of the components from their paper here. I've added some sections to bring some context for people, but they go on to say here, and this is directly from the paper, they say it was later discovered that the oxidation of LDL was initiated by the oxidation of linoleic acid contained within the LDL particles. So there we see the omega-6 linoleic acid. They say, indeed, linoleic acid is the most common oxidized fatty acid in LDL. Once linoleic acid becomes oxidized in LDL, aldehydes and ketones covalently bind ApoB. So ApoB is that protein, that important protein that's present on every VLDL, LDL particle. And basically once the ApoB becomes altered, you basically have, they say you're creating LDL that's no longer recognized by the LDL receptors in the liver, but is now recognized by scavenger receptors on macrophages, leading to the classic foam cell formation in atherosclerosis. So essentially what happens is the linoleic acid becomes oxidized, and you start to get oxidative damage to the ApoB. So we can see that here, mildly oxidized LDL. And then essentially at a certain threshold, when the ApoB and the lipids are completely oxidized in the particle, you start to see highly oxidized LDL, which no longer interacts with the LDL receptor here. We can see interacting with a hepatocyte, and instead activates the immune cells. So the immune cells are basically coming in and saying, what's this junk? What's this damaged LDL we have here? And it's like, all right, well, let's just get rid of it, right? And it engulfs it to try to, presumably to try to protect some of the other cells and tissues from these oxidized lipids and damaged proteins. And then eventually you get these foam cells. So they basically continue here and they say, but it's now recognized by the scavenger receptors on the macrophages, leading to classic foam cell formation atherosclerosis. Hence, the amount of linoleic acid contained in LDL can be seen as the true culprit that initiates the process of ox-LDL formation, as it is the linoleic acid is highly susceptible to oxidation. Additionally, an increase in the intake of linoleic acid, increases the linoleic acid content of very low density lipoprotein and high density lipoprotein, increasing their susceptibility to oxidize, which further increases the risk of cardiovascular disease. So basically, that's what we see here in the graphic. If you have an LDL particle, if you have a normal LDL particle, you have an ApoB protein, you have a bunch of cholesterol and phospholipids and triglycerides here. What happens is you see enzymatic and non-enzymatic factors, so exposure to copper ions or iron ions, or interaction with different enzymes like lipoxygenase, or even myeloperoxidase in the blood from immune signaling. This can lead to oxidation of the lipids, especially if they're very high in the omega-6 polyunsaturated fatty acids. That progressively leads to the complete damage. And again, once this is damaged, it doesn't interact with the LDL receptor. The immune system comes in and cleans this up, right? Because one of the big things for me, Chris, when I was looking at the cardiovascular disease stuff is like, why would this normal component of our physiology just randomly drive this disease process? Why would you have this transport protein that just, like the more of this transport of lipids that you have goes around, it just goes into your vessel wall. We don't exactly know why, but like it just does that. So the more particles you have, the more cardiovascular disease you get. And it's like, it doesn't make sense to me, right? That you have this normal process that would induce damage. You would anticipate that the process, like over time, yes, there'll be damage to the vasculature, but you would assume that it'd be from other factors. And also, when we think about the research that you showed us, how come earlier, like 100 years ago, we're not seeing the same level of disease process? If this was always the case, wouldn't we assume that the heart attack stuff would be going on since time immemorial? And I'm sure that it has. I'm sure that people have had heart attacks. Just they weren't recognized or diagnosed or whatever the deal is. But I think when you look at the rapid change, I think something has had to have changed to have this massive increase versus just like perhaps a more low level experience that was present in the past. And it also that goes hand in hand with the idea that just these normal components that are transporting lipids, it doesn't make sense that they would be inducing this immune response and becoming easily damaged. It's like I don't know, like you're buying the product and it's defective before it even starts to work. It doesn't make, at least for me, it didn't make any sense.
Oh, I totally agree, Mike. It doesn't make any sense at all that that this LDL particle should just, for some reason, it's just going to drive coronary heart disease or cardiovascular disease. That makes no sense at all. And why wouldn't we see this in animals that live in the wild who also have very long lives? You don't see that. Also, I want to point out here, this might be a good point to point out that we're talking about omega-6 linoleic acid a lot. When omega-6 linoleic acid is 90% of the omega-6 fats in any natural fat. So that's why linoleic acid is so incredibly important here. And when they measure oxidized LDL, what they're measuring, the oxidized part is malondialdehyde and 9 and 13 HODE. HODE is hydroxyoctadecadienoic acid. Those particles, those are the oxidized downstream metabolites of linoleic acid. So the very oxidized metabolites are what indicate that it's oxidized LDL.
Yeah, we're actually going to see that too. There's a paper that we have in our presentation here that basically shows some of this. So just with this, I guess the next thing going into this is, well, why is linoleic acid or omega-6 fats, like what makes them so problematic, right? Because, okay, so they oxidize, but why do they oxidize more than monounsaturated and saturated fats? And basically it's a structural problem. It's essentially a structural problem. So when we look at the different fats, you have saturated fats, which have no double bonds. Then you have monounsaturated fats, which have this singular double bond. And you have polyunsaturated fats, this is linoleic acid, that has 2 double bonds. The more double bonds that you have in these fatty acid tails, the more likely they are to be damaged or interact with the components that can create a strong oxidative reaction. And so basically this is a quote here from Life, Death, Metabolic Rate, Membrane and Composition and Lifespan of Animals. This is from A.J. Holbert, who has some really interesting look at membrane composition and lifespan. But they say the carbon atoms that are most susceptible to radical attack are the single bonded carbon atoms between double bonded carbons of the acyl chain. So that's basically what we're seeing here. The hydrogen atoms attached to these carbons are called bisallyl hydrogens. This means that saturated and monounsaturated fatty acyl chains are essentially resistant to peroxidation, while polyunsaturated fats are damaged. Furthermore, the greater degree of polyunsaturation of polyunsaturated fats, the more prone it is to peroxidative damage. So the more double bonds you get, the more likely that fat is to be damaged via a peroxidative process or via an interaction with an oxidative element. Go ahead, Chris.
Oh, no, I didn't have anything to add, except I could just throw in here, and I know you're going to cover this even further. But yeah, the evidence is clear that it's extremely difficult to oxidize saturated fat. It's almost impossible. One lipid biochemist in a paper that I read said, if you want, and this is his word, he wrote, I wish I could notate the paper, but he said, if you want to oxidize saturated fat, throw it in a can of gasoline and light it on fire, because that's the only way to oxidize it. Whereas I know you're getting to these polyunsaturated fats, they oxidize relatively extremely easily.
Well, yeah, and you can see, that's why I put this here so we can compare them and see. But basically, what they say here is Holman empirically determined by measurement of oxygen consumption the relative susceptibility to the different acyl chains. So doxohexanoic acid, DHA, which you find in fish oil, the highly polyunsaturated omega-3 polyunsaturated fat with 6 double bonds is extremely susceptible to peroxidative attack, and is 8 times more prone to peroxidation than linoleic acid, which has only 2 double bonds. DHA is 320 times more susceptible to peroxidation than the monounsaturated fat oleic acid. With the combination of the relative susceptibilities of different fatty acids with the fatty acid composition of membrane lipids, it is possible to calculate a peroxidation index, a measure of the susceptibility to peroxidation for any particular membrane. So basically what you see here is, here's your N6, your omega-6 PUFA. You have linoleic acid or arachidonic acid, 4 double bonds, 2 double bonds. And then you have linolenic acid and DHA. So you have 3 double bonds and 6 double bonds. And what you can see is as you increase these double bonds in the structure, so basically if you look here, the double bonds in the fatty acid tail, they're way more likely to be damaged by peroxidative stress. And you can see here DHA at the absolute max. If we compare that to saturated fats and monounsaturated fats, they're not even registering on the peroxidation index comparatively. And so this is the thing. You're basically, when you have a high amount of linoleic acid in your diet, because you can't make it, it's not something that the body actually makes. It can elongate it and change it into other omega-6 fats, but we can't synthesize them endogenously. So we have to get it in from the diet. And essentially, the more of this you add into your diet, the more you store in your tissues, which, Krish, I know you have some graphics to show us about this later, but also the more of this you have in your tissues, the more likely you are to deal with peroxidative stress when you are put under any type of insult, an infection, if you have micronutrient deficiencies, if you have metabolic dysfunction, etc. And so basically, when we look at this in atherosclerosis, if you have a normal LDL cholesterol, and then you add a large amount of omega-6 polyunsaturated fat, particularly the linoleic acids, which is the major one we're seeing in the diet, as Chris mentioned, or as you mentioned, Chris, you see an increased susceptibility of that LDL to oxidation. And then basically, this is just showing more stuff in humans. They say here that lipids from human atherosclerotic plaques have been found to contain oxidized cholesterol linoleic, so basically cholesterol esters containing linoleic acid. Moreover, the severity of atherosclerosis is noted to increase with increasing oxidized cholesterol linoleic. Healthier regions of aortas have been found to have less oxidized cholesterol linoleic, 5.9 to 9.5%, compared with atherosclerotic regions, which have 12.4 to 21%. So basically, when you look at atherosclerosis and you actually look in the plaques, the more of these oxidized lipids that you see, the more plaques you tend to see, the worse the plaques tend to be across the board. And this is, so it kind of goes hand in hand with this hypothesis that if you increase linoleic acid into those LDL particles and they allow the LDL particles to become oxidized, and the more oxidized LDL particles, the more deposition and damage to the vasculature. Because as we saw, oxidized LDL directly damages the endothelial cells in the vasculature and induces that immune response, which is essential for the development of cardiovascular disease. And this is what you were talking about before, Chris, with the 9-hode, and I don't think they talked about 13 here, but they were talking about the 9-hode. They say on LDL oxidation, linoleic acid converted to hydroperoxides, which can then be converted to hydroxy acids such as 9-hode, so 9-hydroxy, 10-12 octadecadienoic acid. 9-hode is extremely prevalent in oxidized LDL and is a good indicator of lipid peroxidation. In fact, 9-hode is 20 times higher in young patients with atherosclerosis compared with healthy volunteers, and 30 to 100-fold greater in patients with atherosclerosis age 69 to 94 compared with young, healthy individuals. So basically, the more of this, the more like metabolites from linoleic acid, you see the 9-hode here and the 13-hode here. These are from linoleic acid. They're oxidized fatty acids, hydroxy acids. Basically, the worse or the more atherosclerosis you're seeing. And then this is what the same thing basically shows us here. They say in 1952, Glavland and colleagues published a paper showing that aortic lipid peroxides positively correlate with atherosclerosis. These findings were confirmed in 1970 by Brooks et al., who found large amounts of 9-hode and 13-hode derived from linoleic acid hydroperoxides in the aortic plaques. In 1991, Wang and Powell found increased amounts of 9-hode and 13-hode in the aortas and LDL of atherosclerotic rabbits. That same year, Belkner and colleagues found oxygenated cholesterol esters, which was cholesterol linoleic, so cholesterol bonded to linoleic acid, in atherosclerotic plaque of human aortas, the degree of which correlates with the stage of atherosclerosis. To sum up, the increase in linoleic acid hydroperoxide, so damaged linoleic acid in atherosclerotic plaques coincides with a greater severity of atherosclerosis versus normal regions. So this goes directly with what you were saying, Chris, that the more of these oxidized linoleic acid products you have, the more of the ox-LDL, which typically is oxidized from linoleic acid, the more atherosclerosis, the worse the atherosclerosis is. And again, this is related to the structural element of the polyunsaturated fats, where they are very fragile because they have those double bonds. So when you have any type of oxidative stress, and even under relatively normal circumstances, you can see an increase of the lipid peroxidation products, which again, we'll see that just later on. So I don't know if you wanted to add anything in here before I recap this section.
Yeah, the only thing I'd like to throw in here is my own personal testimonial on this, because for about 30 years, almost 30 years, I had a total cholesterol of anywhere between about 330 and 550. And this is not familiar hypercholesterolemia, actually. But I've gotten my cholesterol way down, which I won't go into. But what I do want to point out is that I was, even though most all this time I didn't know anything about nutrition until 2011. And so for almost 20 years, I had cholesterol values like that. But the one thing I was what I was not doing was I was not consuming much in the way of seed oils, because we almost always made our own food, and I avoided seed oils for the most part, even not knowing that that was important. But in 2020, 5 years ago, I had a coronary artery calcium scan, and it was 0. And I attribute that to the fact that even though with these, very high cholesterol numbers, that I did not have any obvious cardiovascular or coronary artery disease.
Yeah, because essentially what you're saying is that because you didn't have the vegetable oils, you weren't able to form as much of the oxidized LDL particles, even though your lipids were high. And so that then you didn't have the vascular damage and the infiltration. Again, it's not to say that running high lipids, I think, like super high lipids is ideal, but it's more to point out that there's more to the picture than just the lipids. And part of that may be from the oxidative stress and oxidized LDL due to the linoleic acid and it becoming oxidized. And then that's starting to induce some of the vascular damage that we're talking about.
Right. And another huge testimonial on this, Mike, comes from Malcolm Kendrick, who's talked about, he was at one point, this is a number of years ago, I heard him talking about the fact that he had collected a pretty large number of patients of his that had total cholesterols from 300 to 850 or so. And they were, proven essentially to not have any any significant cardiovascular disease. They had no symptoms, and or CAC scans, those kind of things were negative. And I don't think he fully understood or gave a reason why, but he knew that it was evidence against the cholesterol theory of heart disease, essentially.
Yeah. I think again, for me, I think there's, I guess this is a good piece here because there's a little nuance in this picture. While I don't think personally that it's just lipoproteins that drive it, I think that say you had vascular damage and dysfunction already present, and then you had a bunch of lipoproteins being presented into the system, and they were loaded with polyunsaturated fatty acids, or you already had the vascular damage present from prior consumption, you could probably still see the oxidation of those lipoproteins and then the driving of the atherosclerotic process. So I think there's a combination of, that's why when I preface this, there's a combination of factors. It's like, if you have a bunch of lipoproteins floating around that are oxidized, that's a problem. That's a huge problem. It's just, the goal is to basically shift the dietary composition so that you have bulletproof lipoproteins, as well as having like a relatively normal lipid panel or lipid profile. It's more than just your regular lipid profile. There's specific markers, at least for myself, that I like to look at. But what I would say in general is it's like getting all these factors under control. You want lipid particles that don't oxidize very easily because you are not loading them up with these very fragile fatty acids. And you also want metabolism of them to be working effectively across the board so that they're not super high for whatever the reason is in that person's circumstance. So it's a combination of factors. And that's why I think we see all this confusion around, do we need to lower lipids? Do we not need to lower lipids? Is there something else going on? Do lipids cause cardiovascular disease or do they not? And I think it's when you start to consider that it's the culmination of factors, you actually get a picture that starts to make sense. It's like, yeah, if your lipids are high because you have metabolic dysfunction, and then they're also loaded with polyunsaturated fatty acids, it's a bad recipe. It's a bad recipe together. But if you have a circumstance where lipids are high because you don't have cardiovascular dysfunction, and it's because you're running a lower carb diet and you're basically trafficking the fats through the lipoproteins, is that going to directly cause cardiovascular disease? And I think at this point, especially if the fatty acid composition of the diet is dialed in, I don't think that's very clear. And I think this is some of the differences that we have to start to understand. Because again, it's a multifactorial process. You have one side that says it's just lipids, and you have the other side saying it's not lipids. But I think it's probably a combination of lipids plus other factors going together, and then also what's in your lipids, right? And that's where the linoleic acid becomes important. That's where the work that you're talking about with seed oils and vegetable oils becomes extremely important, because it's like, where are we getting these fats in our diet? In the most cases, most people are in the Western world or who are eating westernized diets from these processed packaged foods or adding the seed oils into the diet for cooking or whatever the purpose is. It's not people who are going out and be like, had too many almonds. That's typically not the case. So I think that's where it's really important to talk about those relationships. But what I wanted to do, just to recap this process, this is a great image here. It's from a Ramsden paper. And basically what they say, the paper is titled Use of Dietary Linoleic Acid for Secondary Prevention of Coronary Heart Disease and Death, Evaluation of Recovered Data from the Sydney Heart Diet Study and Updated Meta-Analysis. So what they said here, they say omega-6 linoleic acid is the most abundant fatty acid in native low-density lipoprotein particles. Oxidized linoleic acid metabolites are the most abundant oxidized fatty acids in oxidized low-density lipoproteins, which is potentially more atherogenic than unmodified low-density lipoprotein. So basically you have normal LDL particles and oxidized LDL particles. Normal have the linoleic acid, and oxidized have the oxidized linoleic acid metabolites. They say a potential mechanism contributing to the higher cardiovascular mortality in a linoleic acid intervention group is a diet-induced increase in the production of bioactive oxidized linoleic acid metabolites, including 9 and 13 hydroxy-peroxy-octadecadienoic acid and 9 and 13 hydroxy-octadecadienoic acid. So these are the 9 and 13 HODE that you were talking about, Chris, and that you directly talk about inside your book as well, in depth, which is very good. So I recommend people check that out. And say these oxidized linoleic acid metabolites are enriched in the lipid-laden macrophage foam cells, vascular endothelial cells, and migrating vascular smooth muscle cells of atherosclerotic lesions. So we see these linoleic acid metabolites in the macrophages inside atherosclerotic plaques, in the endothelial cells in the atherosclerotic plaques, and in the muscle cells inside the atherosclerotic plaques. They say oxidized linoleic acid metabolites, particularly the isomers and enantiomers produced by free radical mediated oxidation, have been mechanistically linked to cardiovascular disease pathogenesis. Mechanisms include inducing the formation of macrophage foam cells, endothelial cell activation, migration, proliferation, and foam cell formation of vascular smooth muscle cells, and inhibition of lysosome hydrolysis of low-density lipoprotein cholesterol esters. So basically, these metabolites, the oxidized linoleic acid metabolites, the 9 and 13 HODE and HEDE, basically are directly involved in this pathogenesis process. And then they have a really cool graphic here where basically what they show is if you have your low density, your LDL, your low density lipoprotein, it gets loaded up in linoleic acid, right? So that you have cholesterol bonded to linoleic acid. Then you get exposed to oxidative stress. You get oxidized low density lipoprotein, those OX LDLs. They directly interact with the smooth muscle cells of the vasculature. They induce the proliferation, the growth. So that's where you see that intimal layer of the artery starts to thicken. You get the increased immune cell infiltration in response to the oxidized LDL particles. So the immune cells start to come in. And then also the endothelial cells through that LOX1 receptor get activated. And then essentially these start to create this whole damaging process where the endothelial cells can start to die. and start to trigger the immune response. And then that's where, when we come back here, we're seeing this progression occur. The initial damage, inflammation to the vasculature, the lipids start to move in here, the intimal layer starts to thicken, and then this gets progressively worse over time until you have a ruptured plaque. And then basically that's where you start to see the heart attacks. And this could potentially explain why in a period of time, where you're talking about, Chris, like in Sweden or in the early 1900s of the United States, where we didn't really have that consumption of the seed oils, the vegetable oils, we didn't really see the heart attacks to this extent. So I guess with that, I want to toss the baton back to you so you can show us how has linoleic acid specifically changed over this time frame.
Yeah, and before I get to that, Mike, I just want to mention that this is where processed foods in general, now vegetable oils are huge, they're the largest component of processed foods in the United States, and they're smaller components in most other, I mean, smaller than the US and most of the rest of the world, but the worst possible thing you can do is consume lots of seed oils and processed foods that provide little antioxidant capability. So this is where low vitamin E, vitamin C, and all the other things that help manage your antioxidant status, like glutathione. A poor diet in this regard then adds to that risk, because now you've loaded up your LDL with linoleic acid, made it susceptible to oxidation, and you have reduced antioxidant capability availability. So this is a double whammy. This is why processed foods are so bad, because they're full of both. They're loaded with vegetable oils, and they're nutrient deficient, like in terms of the antioxidants, for example.
And then just to add to that, on top of that, when you get chronic consumption of those foods and then you drive the metabolic dysfunction like in the mitochondria, then you get the increased body fat gain, and then you start to get the insulin resistance and metabolic dysfunction. So you have a decreased antioxidant defense, you have an increased production of reactive oxygen species and oxidative stress, and then now your tissues are loaded with basically this dynamite of these polyunsaturated fatty acids that can be easily oxidized. And then so you get this like huge, like basically this conglomeration or this trifecta of metabolic damage from the micronutrient deficiency, the metabolic damage, the metabolic damage can even be caused by the lack of micronutrition as well. And then the increased susceptibility to oxidative stress or oxidative damage from these fatty acids. So it's the full picture is terrible. And that's also why the solution in a large part is you eat a better diet, right? Because then you get adequate micronutrient status, you minimize those polyunsaturated fats, and then it shifts the composition of the tissues, the metabolism starts to work a bit better, and you have enough of the micronutrients present, the vitamins and minerals, so that you can mop up that oxidative stress, and things start to hum along a little bit better.
Right, exactly right. Yes. So, Mike, you ask about the linoleic acid in our diet, and I'm going to present a couple of lines of evidence here that is testimony to this. This graph right here comes from the USDA data, which goes back to 1909, and this was published by Tanya Blasbalg and colleagues at the NIH back in 2011. And you can see here, this is omega-6 linoleic acid in the U.S. diet, 1909 to 1999. And you can see that it's roughly almost, it's more than double. I think it's 2.5-fold increase, something like that, between 1909 and 1999. I don't know. Their graph here, Mike, it's strange because I think the number was 2.28%. is what it was in 1909, if I remember right. But maybe, and for some reason, their graph looks like it's more like 2.7%. But it ended up being 7.2 something percent by 1999. So you can see how much omega-6 linoleic acid has increased during that 100-year period. Now we've extended this on either end. So we actually modeled the diet of Americans back in 1865, when we had absolutely zero seed oils. We had almost no processed foods. All there was sugar. That was the only processed food there was at that time, essentially, and it was fairly low. But anyway, this is approximately what the omega-6 linoleic acid consumption was in 1865 for Americans, 1.1% of the diet, or 2.4 grams. By 1909, that had doubled to 2.23%, or 4.8 grams. You can see that by 1999, it's at 7.21%, or 18 grams, and 2008, 11.8%, or 29 grams. And all of these are published, except for the 1865 one. I mean, they're published in scientific papers, and we have a paper that is pending publication that will document this 1865 one. And so then I like to show this, Mike, that if we look at the omega-6 linoleic acid consumption in 1865 versus 2008, omega-6 linoleic acid, or LA, was 1/90th of our calories in 1865. By 2008, it was 1/8 of our calories. And this makes this, just by the dose alone, it makes it a poison. This goes back, I've used this quote from Paracelsus, going back for myself for almost a decade. He said, Paracelsus, the famous physician and alchemist from the 1600s, I think, said, quote, "All things are poison and nothing is without poison. Only the dose makes a thing not a poison." And people have paraphrased this to "the dose makes the poison," which is exactly right. And I don't care what it is. If you increase the dose by tenfold, which is what we did, with our omega-6 linoleic acid, and you hold that chronically at tenfold the natural dose that you would get, I assure you, it will be poison. All things are poison. This includes water, oxygen, every nutrient you can think of. If you increase the dose of iron, magnesium, zinc, copper, vitamin D, even you just take vitamin D, for example, there's toxicology reports of patients being given 10,000 international units of vitamin D per day, and in 1 year they've got severe vitamin D toxicity. They get hypercalcemia, hyperphosphatemia. This can drive nephrocalcinosis, calcification in the kidney failure, these kind of things. You can't increase the dose of anything dramatically like that without severe consequences. And so this is here's the omega-6 linoleic acid in the adipose, in the body fat, versus the year. And this is published by Stefan Guillenet back in 2015, who is a friend of mine. And anyway, you can see here that this is where the omega-6 linoleic acid was in 1959 in Americans on average, 9.1%. And that had increased to 21.5% in 2008. And then this is from the same paper from Stefan Guillenet. He shows here the percent of LA in the adipose versus the LA intake in grams per person per year. And you can see that you've got a linear correlation. So in other words, the more linoleic acid you consume, the higher it will be in your adipose. So, I've shown separately that the omega-6 linoleic acid in the body fat is around 2.8 to 2.82% on average in the 4 populations who were consuming ancestral diets. That's how low it was, 2.8%. We're at 21.5% as of 2008. It could be even a little higher today in the United States.
So basically, it's just showing us that this is what we were saying before, is that because we can't make these fatty acids, the only way you're going to get them in is from the diet. And then what you're seeing is that as you increase your intake, you can see a change in the body fat percentage of linoleic acid. So the more you eat, the more you have. And then basically the work that you presented from Stefan Guillenet is that over time, the amount of linoleic acid and body fat percentage has increased considerably, and that tracks with our intake. which goes basically, it proves that we have been increasing the intake considerably. So I guess with this said, where are people getting linoleic acid from? What are the major sources that you would say people are getting linoleic acid from?
Right. So if in 1865 we would have gotten linoleic acid primarily from animal meats and animal foods, eggs, milk, and such. But over the next 145 years after that, it dramatically switched over to we're getting this primarily from seed oils. And here, Mike, you can see this is the cooking oil type versus the percentage of linoleic acid in that fat. You can see that in safflower oil, the top one, it's 75% of it is linoleic acid. The most common oil in the United States, soybean oil, is about 53% omega-6 linoleic acid. Canola is down here. It's one of the lowest in the seed oil category. It's 21%. And you can see that corn and soy fed lard, pork lard, is 20%. So it's just like humans. So monogastric animals will get very high levels of omega-6 in their body fat when they're fed high omega-6. And then you can see here that avocado, olive, and palm oil, they're down in the 10 to 14% range. Then you get down to our healthy fats: beef tallow, butter, palm, coconut oil, ancestrally raised lard, beef tallow, and butter. Look at these. They're all between 1.4% and 3%. So all this in the green category, this is where we got all of our fats in 1865. I mean, all of our added fats. We would get linoleic acid in every kind of plant food there is, but the amounts are small. And so we're back to looking at this, that again, the omega-6 linoleic acid has been driven sky high because of our vegetable oil consumption rising from zero in 1865 to 80 grams per person per day in 2010 in the United States. This, Mike, is vegetable oil consumption globally. This is also pending publication from us. This shows vegetable oil consumption again globally. We can see that we were less than about 0.1 gram per person per day in 1865, and that increased to approximately 0.2 grams in 1900, just slightly higher. And then so those are estimates back there. And then by 1961, we've got the FAO actual data. We were at 15.5 grams of total vegetable oil consumption per person per day in 1961, and that increased to 65.4 grams per person per day by 2014. That is a huge amount. I mean, if you think about, even at 60 grams a day, that's 630 calories worth of vegetable oils. So this is the one thing that's been increasing globally, and you can see even in the past decade or 2 decades, it's gone way up.
Okay, so basically we know that we talked about the relationship between seed oils, right, or vegetable oils at this point, with cardiovascular disease, and we see that the trend in cardiovascular disease has increased. The vegetable oil consumption has massively increased, and some of the reasons we talked about why cardiovascular disease deaths have decreased overall, even though the total increase is still massive, is because of treatments and because of the lack of smoking. So where does saturated fat fit in this picture, right? Based on your data, where do you see saturated fat in this picture? Does it corroborate with the heart disease deaths?
You bet. So, this is the next perfect question, because then this is our published graph. We published this in Medical Hypotheses back in 2017, and you can see, we'll just talk about the heart disease deaths in red in the US, again, between 1900 and 2020 versus the vegetable oil. And again, you see this really strong correlation. And then with saturated fat being almost flat through the whole century. So we have 50 grams a day in 1909. And by 2009, a century later, we were at 50, I think it was either 58 or 59 grams a day. So the 8-gram difference roughly in that entire century of saturated fat. So saturated fat barely changed at all. I've always said, Mike, that if we could have published this graph in 1959, you know, after Ancel Keys' famous graph that vilified fat at that point, I think this might have changed the trajectory of where we went, but we didn't get this published till 2017.
Well, I guess that brings me to the next question, which is like, if saturated fat is not really showing this relationship with the cardiovascular disease, then why are we told? What was the initiating factor for having us eat more polyunsaturated fats and then lower our saturated fats? When did that start happening, and why did that start happening from your research?
Yeah, and that started with Ancel Keys. I think essentially, I would say, rather started with him. And I'm not going to be going down this path of trying to demonize Ancel Keys, but this did rather begin with the 6-country study that he published in 1953, which is this paper, Atherosclerosis, a Problem in Newer Public Health. And in that paper, he published this graph that where he had shown these correlations between degenerative heart disease, which is a lot of different kinds of heart disease, but anyway, degenerative heart disease versus the fat. This is just total fat in the diet. And there really is and was a correlation. And I mean, there's been a lot of, I'll just say this, Mike, just very briefly, that there's a lot of demonization of Ancel Keys. I'm not in that camp, and I do, from all of the evidence, I cannot ever see that he cherry picked or hid evidence that he had. All right, many of his colleagues have published what they call a white paper that is in defense of that. I think people should take that into consideration instead of jumping on the bandwagon. What was Ancel Keys wrong? Yes. He was wrong to vilify fat in general and saturated fat. But you asked about the history, and so this is where it is. And this, from his 1953 paper, this is what he wrote, for example, quote, "The present high level of fat in the American diet did not always prevail, and this fact may not be unrelated to the indication that coronary disease is increasing in this country." And he continued, he said, "From the statistics of the U.S. Department of Agriculture, it is clear that the biggest contributor to the fats in the American diet is fats and oils as such, excluding butter, which comprise 46.5% of the total. Meats, poultry, and fish combined make a poor second at 22.1%. And then he wrote this: "Any attempt to reduce the total fat intake must then begin with cooking fats and oils." He wrote this in 1953. That's pretty interesting, despite the fact that he went on to vilify those the saturated fats and exonerate, or try to exonerate, the polyunsaturated fats. But in 1961, Ancel Keys had become a famous person. He was on the cover of Time magazine in 1961. And in that, and if you look up that article, I've just got a couple of quotes out of that article, and they wrote this, quote, "Thus, says physiologist Keys, the big cut in reducing U.S. fat intake should come in the popular saturated fats, which, although more expensive, have become a bigger and bigger part of the American diet. He regards the cause and effect relationship between cholesterol and heart disease as proved." And he did warn Americans to reduce the fat calories in their diets by a third if they wanted to avoid heart disease. And he said this in the Time article. He said, "People should know the facts, quote, then if they want to eat themselves to death, let them. So he was a powerful factor here. And in 1961, so we're kind of backtracking just a little bit here, but in 1961, the American Heart Association, who published the journal Circulation, published this article. And the title is Dietary Fat and its Relation to Heart Attacks and Strokes. And in this article, again, 1961, they advised Americans these three things. These are quotes from the paper: reduce the amount of fat in the diet. That was number one. Number two, substitution of polyunsaturated fat for a substantial part of the saturated fat in the diet. So they're recommending polyunsaturated fats. And then third, they said, quote, and it would seem that the simplest way to reduce cholesterol in the blood is to eat less foods containing cholesterol, end quote. So that was a powerful piece to publish at that time. Then by 1978, the Senate Select Committee of the United States published this document, the Dietary Goals for the United States. And their goals, again, in 1977, were included these. Number one, to reduce fat consumption from 40% down to about 30% of calories. And then second, to reduce saturated fat consumption to about 10% of calories. And quote, this is a quote, balance that with polyunsaturated and monounsaturated fats. And so again, their recommendation was consume about 10% of your calories as saturated fat, 10% as monounsaturated fat, and 10% as polyunsaturated fat. And that exists almost to this day. It's quite similar. So that you can see here, this was when the 1980 Dietary Guidelines for Americans came out. They wrote, avoid too much fat, saturated fat, and cholesterol. And if we jump all the way to today, this is the Dietary Guidelines for Americans. These come out every 5 years in the US. And so this is the 2020-2025 Dietary Guidelines. And they say this, quote, for those 2 years and older, intake of saturated fat should be limited to less than 10% of calories per day by replacing them with unsaturated fats, particularly polyunsaturated fats, end quote. So they don't actually give those numbers anymore, like how much, PUFA, how much polyunsaturated fat we should be consuming. They sort of dodge that issue now, but they're still telling us to limit our saturated fat.
And then basically this was all coming from, so this came from the lipid hypothesis essentially, right? With Ancel Keys' work. And his idea was that the more cholesterol you had, the more atherosclerosis you would develop. And then essentially the goal from his was to lower total fat, lower saturated fat, and then switch for polyunsaturated fat, which this I think will bring us into the next section here, where we'll talk about, the question of does polyunsaturated fat actually lower cholesterol compared to saturated fat? And the answer is basically yes. So we'll jump into that. But that was the general idea, right, Chris? Is that you want to lower total cholesterol, because the more cholesterol you have, the more atherosclerosis. And the way you do that is you lower your total fat intake, lower saturated fat intake, and then you replace specifically with polyunsaturated fat intake. And that's still the regular recommendation that we're seeing across time since that point. So basically it is true that polyunsaturated fatty acids lower cholesterol. And it's through two different mechanisms. So one is through SREBP, which we'll talk about, and the other one is through the PPAR. So there's a paper here titled The Saturated Fat Unsaturated Oil Dilemma, Relations of Dietary Fatty Acids and Serum Cholesterol, Atherosclerosis, Inflammation, Cancer, and All-Cause Mortality. And what they say in this paper, they say the expression of genes that code for enzymes that synthesize cholesterol and other lipids is regulated by a group of transcription factors known as sterol regulatory element binding proteins, so SREBPs. When cholesterol concentrations are low in a cell, a series of events takes place to increase the presence of these SREBPs to promote the expressions of genes for cholesterol synthesis, as well as uptake from circulating lipoproteins. So the cells need cholesterol. It's extremely important for cellular function. So the cells can create them or they can take them up. And it's under the control of this SREBP, this transcription factor which basically induces a bunch of genes that allows you to make cholesterol. They say insulin can also induce an increase in the nuclear, so that this is in the nucleus of the cell, SREBP1, both A and C, which will result in expression of genes for synthesis of fatty acids, cholesterol, and other lipids when carbohydrates are consumed in excess and stored as fat. When cholesterol concentrations are high in the cell, events occur to decrease the presence of SREBPs in the nucleus, which diminishes cholesterol synthesis and uptake from circulation. So basically, the cells are constantly trying to make sure they have adequate cholesterol. If it's too high, they lower SREBP. If it's too low, they increase it to either synthesize it or they can take it up from the blood. Now, PUFAs mess with this process. Polyunsaturated fatty acids mess with this process. So basically what they say is the presence of polyunsaturated fatty acids can decrease the amount of nuclear SREBP1 to decrease the synthesis of fatty acids, cholesterol, and other lipids, with long-chain omega-3s showing the strongest activity in this capacity. Saturated fatty acids and monounsaturated fatty acids do not have any influence on this control mechanism. So essentially, the polyunsaturated fats come into the cell, and they basically lower the SREBP so that you don't get the synthesis of fatty acids or the synthesis of cholesterol. And this is one of the pharmacologic mechanisms by which fish oil lowers triglycerides and lowers cholesterol on top of inducing oxidative stress in the liver and causing a degradation of ApoB100 at the liver before the cholesterol is exported. So basically, the polyunsaturated fatty acids, they do lower cholesterol, but they do it through this kind of blocking this pharmacologic mechanism. And so this is why I think partly why we see them lower it, and this was a recommendation. This is why there's a recommendation to increase them. So it's true that they lower it. And then on top of that, the cholesterol, the polyunsaturated fats also induce these PPARs. So this other element. And this is from the same paper. What they say is, in view of the fact that PPARs exhibit a strong response with polyunsaturated fatty acids and little or no response to monounsaturated and saturated fatty acids, it has become clear that polyunsaturated fatty acids, particularly DHA and other long-chain polyunsaturated fatty acids, can lower serum cholesterol via PPAR alpha. So it's through this nuclear factor. In addition, polyunsaturated fatty acid activation of PPAR gamma can elicit the beneficial reduction of serum triglycerides, increase adipose tissue storage of these lipids, and decrease release of free fatty acids from the adipose tissue. This later mechanism explains the benefits of longer chain omega-3 polyunsaturated fatty acids on insulin sensitivity and glucose metabolism. So the longer chain the polyunsaturated fats, basically the stronger you have this effect on the PPARs, which they basically induce the burning of fatty acids through the mitochondria, through the peroxisomes, and they help to decrease or increase the movement of fats into storage. And what the authors say here, and this is where it gets interesting, they say consequently when polyunsaturated fatty acids are abundant as a result of increased dietary intake, the liver enzymes for beta oxidation of excess polyunsaturated fatty acids and peroxisomes will help to limit the amount of polyunsaturated fatty acids in the body to prevent excess lipid peroxidation. In addition, many polyunsaturated fatty acid metabolites, such as eicosanoids, endocannabinoids, and the oxidized derivatives of 9 and 13 hydroxyoctadienoic acid, which is a 9,13-hode inhede, or 9 and 13-hode, will also activate PPAR alpha in the nucleus. These metabolites and oxidation products of PUFA, or polyunsaturated fats, would be an indicator of sufficient polyunsaturated fatty acids present in the body tissues to satisfy their needs for synthesis of bioactive signaling agents, and the excess should be eliminated. So basically, what the author is implying with these papers is that, particularly with the PPARs, the polyunsaturated fatty acids are lowering these lipids by forcing the burning of the fats or pushing them into fat storage. And the implication here is almost as a way to protect against some of the excesses of these lipid peroxidation products. So it's almost like a protective mechanism to some extent against the polyunsaturated fats to try to keep them lower because they are because of their oxidation products, and their oxidative products trigger some of these responses. And even in some of the studies, when you look at the effects of DHA from fish oil, or you look at some of the things from linoleic acid, that basically what they show in some of the animal models, at least, is that the way that the polyunsaturated fatty acids are inducing some of their benefits is through hormesis. It's by increasing lipid peroxidation. And then the body's like, oh crap, we have all these lipid peroxidation products, so now we need to mount a defensive response to kind of clear this stuff out. And that's where you see some of the antioxidant benefits of fish oils, or even some of the antioxidant benefits in some of the animal models around the polyunsaturated fats and their lowering of lipids is through this process, through activating PPARs, through lowering SREBP, and then also through upregulating other pathways, which I didn't talk about here, but some of the antioxidant pathways and components like this. So this is the interesting piece, is that they do lower the cholesterol, but it's not through a way that you want. It's not through a way where you're taking the cholesterol and you're converting it into steroid hormones or incorporating into the cellular structure. You're basically just lowering lipid synthesis altogether and then forcing the utilization of the lipids to try to get rid of some of these mediators. So the next piece that ties in with this and something to show is that when you're thinking about this mechanism, it's like, oh, well, cholesterol is lower. As we already talked about, the linoleic acid will increase the amount of these oxidized linoleic acid metabolites. So even if cholesterol is lower, now you have lower lipids, great, but now you have lipids that are higher in these peroxidized fatty acids, which is not good at all. Because the question is the problem the total number of lipids, or is the problem really that the lipids are damaged and oxidized? Because if we remember, normal LDL particles don't drive this process. It's oxidized LDL particles that drives this process. So this is a paper. It's titled "Lowering Dietary Linoleic Acid Reduces Bioactive Oxidized Linoleic Acid Metabolites in Humans." And basically what we see is when you lower linoleic acid in a diet, so they went from 6.74% of energy down to 2.42%, which is much closer to the targets that you talk about, Chris. What you wind up seeing is that the total oxidized linoleic acid metabolites drop by 13%. So you see a significant decrease in these metabolites. And I think this was after just 12 weeks. So what they say here in the quote, they say oxidized linoleic acid metabolites are pleiotropic bioactive derivatives. They're derivatives of linoleic acid that have been implicated in a variety of pathological conditions. As a major component of oxidized low-density lipoproteins, so low-density or oxidized LDL and atherosclerotic plaques, oxidized linoleic acid metabolites are reported to play a central role in foam cell formation. So that's those immune cells that are filled with fats and the pathogenesis of atherosclerosis. So they're involved in driving some of the atherosclerosis. They say lowering dietary linoleic acid from 6.7% to 2.4% of calories for only 12 weeks. So it's a short time frame, especially in the stuff that you talk about in the book, Chris, with how long it takes for people to actually lower their tissue levels, being hundreds of days, not just a couple weeks. They say even in a couple weeks, though, and this is something I see with clients. So this paper was with patients with chronic headaches. It significantly reduced the abundance of the 4 measured oxidized linoleic acid metabolites, 9 and 13 HODs, and then 9 and 13 OXO-ODs, as well as their precursor linoleic acid in circulating lipid pools. They said there was no significant difference in oxidized linoleic acid metabolite reductions between the 2 low linoleic acid intervention groups, one with and one without added dietary omega-3 fatty acids, indicating that the observed reductions were primarily due to their decrease in linoleic acid. So basically, even in a couple weeks, just lowering linoleic acid can decrease these oxidized metabolites, which these oxidized metabolites are directly involved with or directly involved in the atherosclerotic process. In this paper, too, they also talk the lipid panel wasn't significantly shifted by lowering the linoleic acid content in the diet, which is good. So basically the key takeaway here for me is it's true that polyunsaturated fatty acids can lower lipids, but I think the way that they go about it isn't ideal. It's through the lowering of the SREBP, so you lower cholesterol synthesis and fatty acid synthesis, and you activate the beta oxidation, so the burning of the fats, so that you can get rid of them, and you push the storage of these push the polyunsaturated fatty acids through PPAR gamma into the fat tissue to kind of get them out of circulation. So it's almost like a defensive response. And I think the best way to do it, so that we lower our exposure to these fatty acids, is basically just decreasing them in our diet down to the levels that you talk about in your book, Chris, down to the ancestral levels. This is a big tenet in the bioenergetic sphere as well. Keeping the polyunsaturated fatty acids to 2% or less of calories is the goal. So that's 4 grams for every 2,000 calories. That would actually be the target, so that you don't, like, whether the lipids are bumped up or not, you don't have a lot of these oxidized fats floating around in those lipids. So I think this is where, you see the decrease in cholesterol. And if you've come from that cholesterol hypothesis, it's like, okay, it makes sense to use these fats. But when you start to look a little bit deeper into the mechanisms around oxidized LDL particles and then what's driving that oxidation process is like, I don't know if I want to lower my lipids, at least through this mechanism.
Right. Yeah. And I've said for years, after a lot of evaluation of this literature, that it appears to me that even though the adipose half-life of fatty acids and linoleic, which includes linoleic acid, is 600 to 680 days, roughly 2 years, and it'll take 3 years to turn over all of your body fat and get your omega-6 down to an ancestral level. 3 years, that is. You will actually be healthier, I think, literally overnight or within days or a week or two, like this suggests. Once you get the seed oils out of your diet, you're going to drop the oxalams, the oxidized linoleic acid metabolites. You're going to drop the inflammatory mediators that come from linoleic acid, and so you'll be healthier that day, literally.
Yeah, I see this with clients. I see this with people.
Yeah.
Even though they've had years, decades of seed oil consumption, you could start losing weight and still fixing metabolic issues, recovering from different inflammatory processes with a diet change within weeks to months, even if they still have the polyunsaturated fatty acids present in the fat depots and the fat stores. So even though it takes time, you could still, just changing the diet around to decrease these things can have a pretty rapid effect, in a couple of weeks. So I think that's the good news, because I think some people, I got to wait 4 years or I got to wait 3 years. And it's like, no, it happens faster than that. So
yeah, it does.
I mean, so with that said, I think the last piece that I wanted to ask you about here, Chris, is in one of the papers that you talked about before, this was from, I think, the American Heart Association. They said in this paper, heart disease remains leading cause of death as key health risk factors continue to rise. And they say fueled by ongoing increases in high blood pressure, obesity, and other major risk factors, heart disease continues to kill more people in the U.S. than any other cause, according to the American Heart Association's 2025 Heart Disease and Stroke Statistics Update. And so while we've decreased smoking and we got these better treatments, there still seems to be this factor that's driving some of these problems, or driving the cardiovascular disease, the coronary heart disease deaths, and the overall heart disease deaths. And they say that part of it is through the obesity and probably through continued increases in high blood pressure, but also diabetes. So the last piece I just wanted to wrap up with is I was wondering if you could walk us through, and we kind of covered this in our previous presentation, but there are direct correlations or relationships with seed oil consumption or vegetable oil consumption and obesity and diabetes. So this could be another mechanism through which they're driving some of the cardiovascular processes through this metabolic dysfunction, right?
Right, exactly. So, I mean, if we can zoom out to 50,000 feet for a moment, that I would say that, isn't it interesting that the processed foods are driving all of this? And, again, which is primarily made up of refined industrial seed oils, refined flours, and refined sugars. But if you look at vegetable oil consumption versus obesity, you see this striking correlation, which we went through in the last video. But this increase in obesity from 1.2% in 1900, when the vegetable oil consumption was about 1 gram a day, and increased to 13.4% obesity in 1961 when seed oil consumption was 19 grams a day, and then 42.5% obesity in 2018 when seed oil consumption was 80 grams per person per day. You see this extremely strong correlation, and it's a very similar situation with diabetes. Diabetes prevalence 0.0028% back in 1890, as reported by Sir William Osler that we talked about earlier. And then diabetes climbing steadily all the way to 13%. It's actually this graph here I put in is a little old. It's diabetes is now up to 15.8%. And again, it's risen dramatically just in the last 30 years in correlation to none other than vegetable oils. So again, the industrial seed oils is what I'm talking about, which is again 89% of our consumed total vegetable oils in 2010. So we have this incredibly strong correlation between industrial seed oils and all of these conditions, from coronary heart disease to obesity, diabetes, and so much more. So this ought to tell us, all this evidence speaks volumes to me, and I hope it does to you, Mike. I know it does, but I hope to everybody who's watching this.
Yeah, so basically what we're seeing is that we have the linoleic acid, which we find in these seed oils, and a lot of them are already heated, right? A lot of them have already been treated, heated. There's already oxidized products present in the oil. People are using them to cook, which makes it even worse. Then it's getting into the tissues. Over time, it can oxidize under just generally normal circumstances. That can drive some of the oxidized LDL, which directly damages the vasculature. Then you also have the driving of these seed oils in metabolic dysfunction or effects of mitochondria, which we talked about in our first presentation together. So you have this culmination of these components coming together on top of the seed oils are generally consumed in processed foods, which are nutrient poor and maybe have other industrial additives that aren't great. So then you have micronutrient deficiency, metabolic dysfunction, and an increased ability for oxidative stress. And that can combine together to increase this cardiovascular risk this cardiovascular deaths overall, despite the decreases in smoking and the improvements in care and treatment overall. And it goes back to the fundamental factor, which you started us out here, kind of brings us full circle. 100 years ago, without all this fancy medical care, all these in-depth tools and medications and surgeries and whatnot, we didn't have the same level of cardiovascular disease, particularly coronary heart disease, that we're seeing now. So something had to have changed in this time frame. And one of the most significant factors is likely diet. And one of the most important factors in there is processed foods, which includes the vegetable oils in a very high percentage.
Right. Yeah. So the take-home message is stick with an ancestral diet. That means, particularly remove all of the industrial seed oils. Soybean, corn, canola, cottonseed, rapeseed, grapeseed, sunflower, safflower, rice bran, probably even maybe peanut and sesame oils. But getting rid of those is the number one thing, the best thing that you can do for your health. And but again, those are all part of processed foods and restaurant and fast foods. So it's actually the take-home message is so simple, not easy to do, but it's very very simple and straightforward.
Yeah, and you do cover that more in your book as well. You cover the direct steps that people can go through. You talk about the different oils and fats, and you also talk about a variety of the mechanisms that we've discussed here as well. So I'd recommend people check out your book, The Ancestral Diet Revolution. And then on top of that, I know that you have a new channel that you're launching. So I don't know if you want to let everybody know about your new channel so they can check you out there.
Yeah, so we'll be publishing a lot more to our YouTube channel. It's just under Chris Knobbe, MD, and we'll be publishing to social media as well to try to capture more people, get this message to more of the world. So we appreciate everybody's following that.
Yeah, awesome. So check out Chris at Chris Knobbe, MD at YouTube. And as always, Chris, I appreciate you coming on with me and sharing this information. I know you've worked quite a bit, spent many years putting all these graphs together and parsing through quite a bit of research. So thanks for coming on. Appreciate your time. It's an honor.
Mike, thanks so much for having me on. And, my hat's off to you for the extraordinary amount of work that you've done too to understand all of this, particularly your biochemical and metabolic knowledge. It's off the charts. So I love putting this all together, and I hope it's a great take-home message for all those watching.
Yeah. Yeah, thanks. I appreciate that, Chris. And thanks everybody for watching. We'll catch you in the next episode. Take care. Bye-bye.
Bye.